The broadcast is now starting.
Good afternoon,
All attendees
everyone.
are in listen-only mode.
Good afternoon. Can you all hear me? Please send me a message or raise your hand. Hello? Yes. Good, good. Okay, more please. You all can hear me without any problem. That's great. Very good. Thank you all. Thank you all. Thank you for attending the second lecture of part 1, Pharmacology, Global Medical Education. Essentially, we covered pharmacokinetics, and I covered this lecture actually last time too, briefly. But lecture 2, actually, I wasn't able to process it and save it. So I decided to repeat this lecture to you guys, and I will process it and develop it and place it on YouTube. I already uploaded the previous 2 lectures, pharmacokinetics, the first one on YouTube, and also biochemistry. We're going to have a lecture on Thursday on endocrinology, and that also will be processed and will be uploaded on YouTube. So just if you click on Global Medical Education, Part 1 Pharmacology, you will see pharmacokinetics and biochemistry. I appreciate the fact that some of you attended also community and health, global health education webinar series, where I addressed nutritional aspects, and I addressed actually also diabetes, and I will try to continue my activities with global health education as well. With that said, let's move on and look at what we like to cover today. And I actually revised the second lecture, and I introduced all the molecular mechanisms, signaling mechanisms. So let me first go through the objectives, and let's enjoy this topic before we move on and talk about autonomic nervous system in some detail. With this lecture here, I'm going to introduce you actually to adrenergic and muscarinic receptors as a first start. So I'm preparing you actually for autonomic nervous system. So when you get there, you will not feel lost actually. So please, please, please enjoy this lecture with me. Pharmacodynamics. That's the second part of general principles, and as I stated, this section, pharmacokinetics and pharmacodynamics, constitute about 30% of USMLE questions, because there is a lot to cover before you move on to the classes. The main objectives that we like to address is first to classify mechanisms of action of drugs. We like to understand how drugs act. Are all drugs have to have receptors? And what is the nature of the receptors? So we're going to spend some time in defining mechanisms of action of drugs, and then we'll hit the target of pharmacodynamics, basic principles that deals with our understanding of what is meant by agonist, partial agonists, antagonists. Appreciate those terms before we move on and talk in some detail about adrenergic drugs, cholinergic drugs, muscarinic receptors, adrenergic receptors, specificity. We like also to appreciate and understand specific terms that deals with affinity, efficacy, and selectivity in the context of drug-receptor interactions. We like to understand what is meant by potency of a drug and how is that reflected in a graph. Can we compare between two drugs and determine which one have the highest affinity and efficacy and potency? What are we looking for when we look at graphs? When we look at graphs also, we should be able to distinguish between reversible and irreversible inhibitions based on the analysis of these graphs. And please, I like you to sleep on this material before you move on and address molecular signaling mechanisms. It's very essential to look at a graph and to pick up the right answer in a matter of seconds. The way you're going to do that is to have a full understanding of those terms and to know exactly what you are looking for, just exactly as some of the examples that we shared with pharmacokinetics. After that, we're going to move on and talk about molecular signaling mechanisms. On Thursday's lecture on endocrinology, I'm going to repeat endocrinology, molecular signaling mechanisms from a hormonal point of view. But here, let's address it from a drug mechanism point of view. Drugs that can interact with the specific receptors on the cell membrane. Drugs that can activate G proteins. Drugs that can have a cascade in order to produce the effect, versus drugs that can act intracellularly. The receptors are not on the cell membrane. When we address molecular signaling mechanisms in some detail and with fine elaboration, we should be able to move on and address adrenergic, muscarinic receptors and neurotransmitters and the classes of those receptors. We should be able to give you examples that can facilitate your learning process when you move on and address in detail adrenergic, cholinergic drugs, deal with those detailed receptors, specificity aspects, prepare you for autonomic nervous system and central nervous system. We'll do the same with respect to neurotransmitter receptors. And as I stated here, as a follow-up to it, compare and contrast membrane receptors and intracellular receptors. You have to have a clear understanding of the mode of action on those receptors. When we address molecular signaling, we're going to spend some time and talk about ion channel linked receptors. You have to have a full understanding of ion channels before you move on and address details in autonomic nervous system. So we'll help you out, we'll help you to get up there to this level. And then we can move smoothly toward various classes of pharmacology. And we appreciate them too. What is the term pharmacodynamics refers to? As I stated before in my introduction in lecture 1, we are interested to understand what the drug does when it gets into the body. Pharmacokinetics is other way around. What the body is going to modify or do for the drug. But here pharmacodynamics, what the drug does when it gets there. What kind of receptors is going to interact with, or non-receptors, or enzymes. So it's the biochemical and physiological mechanisms of drug action. When we address various mechanisms of pharmacodynamics and of drug actions, we can easily classify the mode of action into 3 classes. Receptor interactions, and as the name implies here, you're dealing with specificity. So the key word for receptor, I like you to keep it in mind, you are dealing with a specificity action. M1, M2, alpha and beta receptors have preferential binding to specific drugs, and therefore they produce different actions. Enzyme interactions. There are certain drugs act on enzymes. Numerous monoamine oxidase enzyme inhibitors or antidepressant agents. So we'll share some of this information with you. And then non-specific interactions, physical changes, surface changes. Not all drugs has to follow the route of receptors or have to have an effect on enzymes. Let's first address the non-receptor mechanisms and get this out of the way, and then move on to receptor mechanisms, and then spend our time on drug-receptor relationship. When we address non-receptor mechanisms, as I said, action on enzymes. As you all know, enzymes are biocatalysts. And essentially, in simple terms, drugs will tend to alter processes catalyzed by those enzymes. Choline esterase inhibitors is a very good example. Very good example. We're going to deal with that. We're going to spend when we talk about cholinergic drugs. How you enhance choline before you break it apart. Monoamine oxidase inhibitors, as I said. Para-hydroxyamphetamine, pargeline. They act with a great specificity on monoamine oxidase enzyme, which is significant in controlling biogenic amines and central nervous system. A mechanism as a non-receptor interaction of a drug is, as you all aware of it, combining with other chemicals, antacids. Your main objective here is to raise the pH. So antacid is a good example for that. Antiseptic effects of alcohols, phenol, and chelation of heavy metals. Have you heard of chelation therapy, for instance? Very common, and there are physicians actually established chelation therapy centers, especially with those patients who deal with Wilson's disease that can take place as a result of toxicity of copper. So the term chelation here, as you probably heard before, you're trapping this heavy metal. So EDTA, ethylene diamine, tetraacetic acid at very low concentration can act effectively as a chelating agent. Certain drugs change cell membrane permeability. And we will see that in the coming slides. Certain drugs function as antimetabolites, competitors like HMG, coenzyme E, reductase inhibitors, statin compounds, function in this manner. Compete with the natural substrate for the active site of HMG coenzyme E reductase enzyme, which is the most crucial step in synthesis of cholesterol. Enter biochemical reactions in place of normal substrates, so that's the name implies, and as a result of that, you will end up with an inactive product or a less active product. Some examples for changing cell membrane permeability is lutein, blocking sodium channels with Brimpel, blocking calcium channel with Beryllium, and we'll see that very soon when we address classes. Blocks potassium channel adenosine is a very effective example. So have an appreciation, have an outlook of some of those examples, and we will spend our time in dealing with their mechanism of action. Now we are ready to move on to drug-receptor interactions. So we have to be able to define and to understand clearly what is meant by agonist, antagonist, partial agonist, partial antagonist, irreversible antagonist, and reversible antagonist. So as I stated in my introduction last time, agonist is a drug that can bind to the receptor and causes the effect. It gives you a response. A drug binds to effector to produce a physiological response. That's an agonist. Activates these receptors, modifies these receptors, changes the conformation of this receptor. Antagonist is other way around, a drug that blocks and prevents the response, the production of the response. Okay. If you have too much of the effect, so you have to slow it down. So you have to utilize an antagonist drug. You cannot make the situation worse and use an agonist. If you have too much of agonist, you can reverse the process by selecting an antagonist. So a natural compound or a drug to have an effect on a receptor. In terms of terminology, as the name implies here, competitive, they compete for the binding site. And if you are dealing with a competition, you can expect this competition to be reversible or irreversible. Of course, it's reversible if the nature of the binding of the drug is a non-covalent linkage. So you can work with the binding site. If you want to reverse it, you can add more of the natural product, the natural substrate. Just think about enzyme competition here. Very much the same. Very much the same. And as the name here, irreversible binding, it's a competitive but irreversible. Why is that? Because it forms a covalent bond with a group in the receptor. And if the receptor is an enzyme, so it tends to form this covalent bond. And the best example I can give it to you is pargolene as an antidepressant agent that tends to bind with monoamine oxidase at the active site, but it loves to bind with the FAD, flavine adenine dinucleotide. So the enzyme essentially has to commit suicide. So it's competitive, but it's irreversible. I hope I explained that in a nice fashion to all of you. The term non-competitive, it can bind to anywhere else and has an effect on the receptor. When we address antagonists that tends to block the receptor from producing the effect, we can subclassify that into functional antagonists, that's physiological antagonists, or chemical antagonists. Examples for physiological antagonists are, for instance, glucocorticoid hormones. So they tend to produce a change, physiological change. So drug can bind to a non-related receptor, producing effect opposite to that produced by the drug of interest. Glucocorticoid hormones tends to raise the pH. Insulin tends to raise blood sugar. Insulin will tend to lower blood sugar. So that's an physiological antagonist. With a chemical antagonist, we stated about the function of a chelator that tends to trap heavy metal, interact directly with the drug being antagonized to remove it or to prevent it from binding of the receptor. So this is an actual chemical effect. Examples for a chemical antagonist. As we stated, the antagonist does not depend on the level of interaction with the agonist receptors, but it can bind at other site. Heparin is a good example for that, anticoagulant, acidic. If there is too much, so you expect bleeding and hemorrhaging. Protamine sulfate is a good example for that. Why? Because it forms stable inactive complex with heparin, so it removes it. It can knock it off. It inactivates it. So function as a decent antagonist. The term synergism, you have two drugs that can make the effect very pronounced. The combined effect of the two drugs is higher than the individual ones, and that's the terminology aspects. The term additive is the sum, is the combined effect of the two drugs equal to exactly the sum of their individual effects. So we understand what's meant by agonist, antagonist, classes of antagonists, competitive antagonists, reversible, irreversible, synergism, additivity. How about partial agonists? As the name implies here, the drug can bind to the receptor but causes partial response. Last but not least, before we move on toward analysis of graphs, potency. When you say this drug is potent, you're referring that this drug actually can achieve the effect with a low dose. Absolute amount of drug required to produce an effect. So the more potent the drug, the less or the lower dose to cause the same effect. With that, we covered all the terminology you need in order to understand drug-receptor interactions. Let's now look at this beautiful graphs and make some sense out of it. This is the semi-log of dose response curve. What you see here on the y-axis is the effect. On the x-axis is the log of drug concentration. And you see a sigmoidal curve. Why is this sigmoidal curve? Again, as I stated in lecture 1, it tells you that you are dealing actually with binding of a receptor that is not a simple protein. It's a complex protein. So it should not give you the decent hyperbolic plot that you are used to it. It should give you similar plot to what you see actually with hemoglobin saturation with oxygen, not with myoglobin saturation with oxygen. No, hemoglobin, because it's made up of 4 polypeptides you see that with complex enzymes in biochemistry that govern actually key steps in synthesis, like fatty acid synthase enzyme, glycogen synthase. Okay. So you see this sigmoidal plot, and in a very similar manner that you dealt with it in a biochemical terms, so you can address it here. You're looking at a potency that can express the effective dose at 50%. Okay. And you can compare that with other drugs because you have here the drug concentration. So we understand a potency here is the effective dose that gives you 50% of the effect. What is meant by the effect? You're dealing with efficacy, the maximum effect that can be produced, just like Vmax with an allosteric enzyme in a similar manner. See, you remember Vmax for an allosteric enzyme and the apparent Km for an allosteric enzyme, an enzyme that have multiple sites. That's very much the same. Very much the same. So we understand what's meant by efficacy, we understand what's meant by potency, and we understand what is meant by ED50. Okay, I have a question here. Would this lecture will be uploaded in the net? Yes, yes, thank you. But I don't want you to leave for that. I enjoy having you here. When you look at pharmacodynamics, and let's analyze this, and this is a kind of patterns that you're going to see in a standard exam. So you look at this pattern here, yes, agonist alone. We understand all the terms. You achieved here maximum efficacy. Halfway, you can very much get ED50, effective dose at high at 50%. But suppose you added a competitive antagonist. So what will be the effect? You're essentially increasing the ED50. That makes sense. Why is that? Why are you increasing the ED50? Because you're decreasing the affinity of the receptor toward the drug. In a similar manner, that's what you dealt with an allosteric regulation by a negative modulator. So you can simply visualize the effect of an antagonist as a negative modulator that tends to increase the ED50. If you want to put it in a biochemical terms, you can say it tends to increase the apparent Km value and therefore lower the affinity of the drug toward the receptor. How about if you're facing an antagonist? Okay. Suppose you achieve this, that's the same plot that you got it here. Let me use an arrow for that, or a highlighter. So you see this one here. We understand what the shift means when you deal with agonist with a competitive antagonist, and why we should be able to interpret it easily. Let's look at this pattern here. You have agonist alone and effect of antagonist. What does it do? Lower the maximum efficacy. Lower the maximum efficacy. If you look at it in a logical sense and you try to deduce, you try to get the ED50, you will not see a change of the ED50. Why is that? Because this is an irreversible antagonist that does not bind with the binding site of the drug. It somehow modifies the receptor, and as a result of that, you're decreasing the maximum efficacy. This is lowered. But if you get E50 here, if you get E50 here, you will be the same. Just exactly as when you deal with an irreversible negative allosteric modulator for an allosteric enzyme. Same manner. If you understand those terms, you should be able to analyze those plots. You do need to have a full understanding of those terms. I wish there is other way around, but it's not the case. Okay, let's move on and look at this beautiful plot here. Let me get my lighter, my spot, or my arrow. Which one do you prefer? Arrow or a spotlight? I like this one. Okay, drug alone with a non-competitive antagonist. You see the term here, non-competitive antagonist, so you're not competing with the binding site. Therefore, you do not expect to see any change in the ED50. See the ED50 for the drug alone or in the presence of a non-competitive antagonist is the same. Why is that? Because you're not dealing with the binding site. You're dealing with a site other than the binding site that tends to have an effect on the maximum efficacy. You lower this maximum efficacy with a non-competitive antagonist. With a partial agonist, as the name implies here, partial agonist, you are competing with the binding site. But it's partial, and that's why you increase the ED50. With a competitive antagonist, yes indeed, you are affecting the binding site. Therefore, the ED50 will be much higher in the presence of a competitive antagonist comparing to the drug alone. But are you going to achieve the same efficacy? Are you going to see the same Vmax here? Yes, you're going to see it here. Why is that? Because you're dealing with a competition, which means you can reverse this process if you remove it. If you add more of the agonist, you can remove this back. Okay? But you don't see that when you use a non-competitive antagonist. Is that crystal clear to all of us? Yes or no? I want to get your view on that. Okay, good. When you look at cumulative percent of patients responding to plasma level, so we're talking here about we're shifting to therapeutic index, and I mentioned that in the first lecture, so we can go over that very fast here. So you're dealing with a narrow therapeutic index versus a broad therapeutic index. You're looking at the desired therapeutic effect region. So certain drugs have a narrow range. Those are the serious ones that you have to pay attention to it. Warfarin, for instance. You have to be very specific. There is no playing around now with the dose, because the safety zone is very narrow. But with others, like penicillin, yeah, it's kind of, you can work your way through. So that's the terminology. There's some stuff that we dealt with last time, so I'm not going to spend lots of time on that. Therapeutic index, drug concentration, tolerance and dependence, interactions, side effects or adverse drug effects. Let's just fish out mathematical manipulation of therapeutic index so you can have a clear idea about it. Always keep in mind the patient's history, patient health history. Keep in mind drug-drug interactions. Keep in mind age. Keep in mind possible side effects and adverse effects. When you look at therapeutic index, we know what's meant by ED50, effective dose at 50%. So once you achieve the maximum efficacy, you can extrapolate at 50 and get the concentration of the drug. That's what gives you the ED50. In a similar manner, you can do TXD50, and the therapeutic index is the ratio of the TXD50 over ED50. So I stated here, as long as the slopes of the curves are similar, however not similar, so we use the same standard safety. And you can, the standard margin of safety is addressed in this fashion. And it's just one-time deal. You don't have to really panic too much. So that determines the percent to which the dose effective in 99% of the population. And that must be raised to cause a toxicity of about 1%. It's a simple terms, and that actually more of pharmacokinetic aspects. I'm not going to deal heavily with that. You can see the elaboration here about the therapeutic index, toxicity. So that's ED50 presented to you here, and the toxic effect that you see it with. So ED50, ED99, so those are the terms that you are dealing with it here. With that, we very much completed definitions, receptors, non-receptors, pharmacodynamic parameters, analyzing graphs. And what's left for us is to talk about signaling mechanisms. That's very good. Thank you. Thank you. It's very clear. That's good. So, do you wish to take a break? Because I see that your guys, I do not want you to be bored. That's the whole issue. So with that said, I like you to enjoy the break until probably a 10 minutes break. I have here my time is 10 minutes to 3 Eastern time, so let's meet at 3 o'clock sharp. Thank you and have a great break. I'm going to let you listen to the music and enjoy the bird that you saw. If you want another bird, I can easily get it for you. You tell me what you like the most. Thank you and see you in 10 minutes. Welcome back to you all. I got some comments that you guys like the music, and there will be more to come. Okay, before we start the second section, I would highly appreciate it if you send me your comments, email it to me, hzeidan@aol.com. Right after the lecture, so I can tune myself up for the incoming ones. Highly appreciated. And some of you asked is this lecture will be online? Yes, I'm going to produce it and it will be online along with Thursday 1, 2. Let's get started with molecular signaling mechanisms. Now, as I said, keep in mind that we address it from a drug action point of view. On Thursday, we're going to address it from a hormonal point of view. Okay, and will be with more elaboration as well. When we talk about molecular signaling mechanisms, we already define what's meant by agonist, full or partial, that binds and activates the receptor. Antagonists bind and cause no activation. The term ligand refers to small molecules that binds to a large molecular weight species, and we are dealing with the receptor here. So a hormone can be considered a ligand, a drug can be considered a ligand, an ion can be considered a ligand. So you have to keep that in mind. A neurotransmitter can be considered a ligand. So that's some simple terms you're dealing with. With that said, so you're going to see actually the classes that we talk about here in terms of receptors, agonist. Okay. So you have a direct effect, and it depends on the location of the receptors. So if it's an intracellular receptor, so you're dealing with genetic modulation. Okay, same terms that we will address and did address actually with the endocrine system as well. Antagonists, you expect no effect, endogenous mediators, biochemical effect. An ion channel, you are aware of it. Okay, it's facilitated, the opening of a channel is facilitated by binding of an ion. So you see here several examples. Okay. Once the ion came in, so you're opening this channel and you modulate the opening by existence of an ion. So increased or decreased opening probability. With enzyme, so you're dealing with physiological effects. Some of the receptors can function as an enzyme. Okay. And when you have a false substrate, a competitive inhibitor, so that tends to kick the natural substrate out. When you have a pro-drug, it has to be converted to an active drug first. Okay. A transporter, as the name implies here, the ligand bind first, and then what you expect to see is a gradual conformational changes with the transporter. You can see that, so it flipped other way around to unload, to load the drug or the effector here. False substrate, as the name implies, does not give you actually this effect. What are we dealing with here with membrane receptors here? We already addressed what's meant by a ligand. You're dealing with 4 classes, and that's important to appreciate. First class is ligand-gated ion channels. That's what you're going to see actually with central nervous system intensively. See, why is that? You have the ions can cause this a change to take place, hyperpolarization or depolarization. So you can destabilize this electrical potential. You can increase hyperpolarization, you can increase the polarization or decrease it by the opening up of the ion channel, and as a result of that you expect to get the cellular effects. As I stated, you will see that a lot with cholinergic receptors, see nicotinic receptors, so those are the examples that are listed to you here. So have an appreciation about this. Oh, I'm sorry about that. Yeah, nicotinic and cholinergic receptors here. The way this, so this is ion-gated channel, so that's, we refer to this as ionotropic receptors. The second mechanism deals with G proteins, and you have to appreciate the fact that there are 2 classes of G proteins, stimulating G proteins and inhibitory G proteins, and you will see examples of that as we move on and talk about bipolar medication, effect of lithium and stuff like that, so you will see that clearly. Essentially here you have a cascade, so you have the ion channel, but then it's followed by a cascade. So the ligand binds to the receptor first and can stimulate either the stimulatory G protein, that's a positive one, or the inhibitory G protein. And as a result of that, you see, you expect to get an effect on the second messenger. So G protein here, what is, so you have an enzyme here being modulated. In some cases, like for instance, protein kinase enzyme. Okay, an enzyme. And that actually send you a second messenger. The second messenger can be cyclic AMP, for instance. Okay. So the second messenger, what does it do? It phosphorylates proteins, right? So you have that effect. And you also can get a second messenger as a release of calcium. When you phosphorylate proteins, you tend to activate it in this fashion. And when you activate it, what do you get? You get cellular effect here. So we're going to see that actually with cholinergic receptors. We're going to see that with muscarinic receptors. When you talk about the time scale, of course, it's a matter of milliseconds here with respect to the ionotropic receptors, because you're not dealing really with G proteins or enzymes. You're not dealing with this cascade, so it can take, it's a matter of milliseconds. But this one takes a little bit longer in terms of a second. Now you have the kinase-linked receptors, so that's the tedious cascade here. Okay, so you have protein phosphorylation, okay, and you have gene transcription. When you deal with gene transcription, protein synthesis in order to get an effect, so you have to appreciate the fact that that will require hours. So you can see the time scale actually is much longer. Where are you going to see that? With cytokine receptors. That's the kinase one. Now, how about nuclear receptors? The receptors, they are not located on the surface. Those are the receptors here, they are located on the surface. Ion channels located on the cell membrane here. But those receptors are intracellular receptors. So gene transcription and protein synthesis, and what did we say about when you have this cascade, gene transcription, protein synthesis, that will take a longer time. In analogous manner, we will deal with intracellular hormonal action versus membrane hormonal actions, T-half and stuff like that. So in a way, it resembles mechanistic wise. In a way, it resembles hormonal actions. Where do you see that? Estrogen receptors. Okay, so now we have those four classes: nuclear receptors, kinase-linked receptors, G-protein coupled receptors, and ion receptors. Few words about intracellular receptors here. We already mentioned binding of hormones or drug will release regulatory proteins that can affect actually dimerization of the hormone receptor complex, and in such a way to modify the DNA transcription process and change the gene expression and changing the protein synthesis. That's the intracellular receptors. We'll have our share on that in Thursday's lecture. Adrenal, gonadal, steroids, thyroid hormones, and vitamin T. Membrane receptors directly coupled to ion channels. What are we looking for here? You see, now we're really getting to the serious stuff. We're preparing you really to move on and understand the incoming material here. You're dealing with nicotinic receptors for acetylcholine. Nicotinic receptors are coupled with sodium-potassium ion channel. Okay, so that's an ion channel. But in order to modulate those receptors, open up those receptors, you have to have, it's an A must, you have to have this requirement of ions. What else? You have chloride channel. Okay. That's the central nervous system, as I promised you to do that. Okay. You will see GABA, gamma aminobutyric acid, A receptors in central nervous system, and that is coupled with chloride channel. See that? So essentially, those receptors wait for the chloride to bind in, and then you have the opening that takes place. Glycine receptors, serotonin receptor subtype, follow the same pattern. The response here is rapid. Why is that? Because ion channels do exist on the cell membrane. So it's a matter of milliseconds, because it doesn't require really a cascade. It doesn't require GS or GI proteins, doesn't require protein kinase. Okay, and it doesn't go intracellular. The ion channel linked receptors. Okay. So again, those small molecules, including drugs that gate the channels, are neurotransmitters. So you see that. Where do you see that? Yes, you see that with nicotinic acetylcholine receptors. You see that with GABA, gamma aminobutyric acid receptors, that loves to bind with benzodiazepine receptors. Okay, and those are chloride channels for receptors. GABA C also open chloride channels. Glycine receptors are blocked with strychnine, which is poison for rats. So in a way, ion channels are in fact responsible for the conductance of ions. We all understand that. Common ions that you're going to see it in central nervous system: sodium, potassium, calcium chloride. So now we have an idea what kind of mechanism of actions you expect to see. when we have an appreciation about those mechanisms. So the action of these channels will affect essentially the polarization state of the cell membrane. Once you imbalance this electrical potential, so you expect to see hyperpolarization or depolarization. That's the issue here. And therefore, those ion channels will act as the molecular mediators for the polarization state of the cell. Central nervous system drugs target those channels, and we'll see that, and will have significant impact on diverse number of diseases. Let's look at some specific ones. G-protein coupled receptor. We already know what you are looking for here. We said GS and GI. So let's have an example for that. 7 transmembrane proteins. Complex site of ligand binding. You're dealing here, as I said, you're dealing with G proteins and other effectors. So what kind of mechanisms those follow? Adenyl cyclase, don't leave home without it. See, adenyl cyclase that cleaves cyclic AMP from ATP. This is considered a second messenger here. So you're dealing with, first, binding with the ligand, binding with the drug to the receptor, will activate G protein or will inhibit G protein. If it activates G protein, you got it made, you're producing cyclic AMP. Cyclic AMP is a second messenger. Why is that? Because it's going to send the signal to protein kinase A as apple. Keep that in mind. That tends to phosphorylate many enzymes, so you work it your way through. On the other hand, those are the examples. You see receptors linked to GS stimulating G proteins. So it tends to increase cyclic AMP. So you have catecholamine, dopamine, glucagon, histamine, and HT. That's the story. That's a lovely story. So you have a receptor in here. You have the ligand bind to it. Okay, and what do you do with GTP? So GTP, G proteins will hydrolyze GTP to GDP and inorganic phosphate. So it's going to phosphorylate this receptor. Okay. And so you're going to exchange actually GDP, kick out GDP and place GTP on it. Activation takes place, okay, and then GTP is hydrolyzed to GDP and inorganic phosphate, and the process will be repeated. So you're dealing here with resting state versus GTP hydrolysis. Keep in mind, GDP is replaced by GTP. Good. So that's a function of G proteins. There are other ligands that can bind to the receptor and tends to activate GI proteins. So it will work other way around. It will decrease the production of cyclic AMP. See, decreasing cyclic AMP. Those include catecholamine, muscarinic, M2 receptors, dopamine. So it's important. I'm giving you here the alphabet that you need to understand. Is this will be forgotten? No, we're going to address that in detail when we move on to cholinergic and adrenergic drugs. When you deal with muscarinic receptors, cholinergic receptors, M1, M2, D1, D2, and specificity and requirement and side effects, antagonists, agonists, all of that will be elaborated. Now, Let's look at the phospholipase stuff. So we already mentioned that when you activate G proteins, you can have adenyl cyclase activated to release cyclic AMP, and cyclic AMP is considered a second messenger. You can have also guanylate cyclase activated, and you can release cyclic GMP, which in turn can activate protein kinase G. Cyclic AMP here activates protein kinase A, and both of those actually have a phosphorylation effect on enzymes, transport proteins, and so on. What else do we have in addition to cyclic AMP, cyclic GMP, that you're going to see it actually with nitric acid? Okay. Keep those mechanisms in mind because it will be repeated again. You have phospholipase C. Phospholipase C. So phospholipase C, yes, you are dealing with calcium. See here, you're dealing with cyclic AMP, cyclic GMP. Here you're dealing with calcium. See here, see this arrow. Let me get my spotter here so you can feel relaxed, and I don't want to lose any of you. See that? Calcium. Look at this. Cyclic AMP, protein kinase A, cyclic GMP, protein kinase G. Okay, clear on that? This is the story here, and when you talk about bipolar problems, we're going to deal with that. Believe me, function of lithium and stuff like that. A beautiful story. And I have it also in the endocrine system, if you attended Thursday's lecture. So with phospholipase C here, what are we activating? We are activating actually the release of IP3 from phosphatidylcholine, phosphatidylinositol. I refers to inositol triphosphate. So phosphatidylinositol can be cleaved off to inositol triphosphate and diacylglycerol. Diacylglycerol can give you AA, and then you can produce eicosanoids. Now, this is the story about the release. It's tied with IP3 here. So you're going to increase calcium ion, so you have an effect on contractile protein. And the way here you recycle that and you rebuild up again inositol triphosphate. We're going to learn actually that the function of lithium later on as an effective bipolar drug is to interfere with the cycle. So it will not happen. So you have the calcium will not be at high level. Now, diacylglycerol will tend to activate protein kinase C. So pay attention to protein kinase C versus protein kinase A versus protein kinase G. They're very tricky in standard board exams, and I saw that. They can tell you protein kinase A. They expect you to know that that's linked with cyclic AMP. Protein kinase C, that's linked with diacylglycerol. What that is going to do is going to open up ion channels, and it has some effect on contractile proteins. Good. So we're done with that. This is the story here. Receptor systems are coupled with G-alpha protein, and you have inositol triphosphate. And all the story that I mentioned in terms of phosphorus. So again, pay attention to protein kinase C, protein kinase C, protein kinase A. Once you see A, you're referring to adenyl cyclase. Once you see C, so you're referring to phospholipase. Okay. When you're going to see that? You're going to see that with cholinergic drugs. You're going to see that with M1 and M3 receptors. You're going to see that with norepinephrine. You're going to see that with angiotensin 2, angiotensin 1, kidney, and also hypertension. You're going to see that with opioids, central nervous system drugs. So you have a lot to look for. And I already told you, cyclic GMP tied with nitric acid signaling. Right? Remember that. Right. Cyclic GMP tied with nitric acid signal. So it's very important for vascular smooth muscle. It's considered a second messenger. And facilitate dephosphorylation of myosin, light chains, preventing the interactions to take place. Nitric acid, NO, which can be formed from nitrate. And that's essentially the function of Viagra, if you recall. And that will be addressed to you. So always keep that in mind. So I'm giving you here some very invaluable information to deal with. So nitric acid linked to nitrate, as you can see here, and released from the endothelial cells by vasodilators and tends to activate guanyl cyclase to release cGMP. How about receptors that have enzyme activity? Are we going to ignore that? Not indeed. No, we're going to include it. Enzyme inhibitors. You're going to see that guy here, carbonic anhydrase. We'll have a good story about it. We'll talk about the nephron structure and stuff like that. Classes of drugs. Cyclooxygenase enzyme dealing with blood clotting. Cascade. Dihydrofolate reductase, you remember? Don't leave home without it. N5, N10, methylene tetrahydrofolate, N10 methyl tetrahydrofolate, all of that. So you're going to see that there are specific drugs that methotrexate, right? Remember that? Methotrexate is a common competitive inhibitor for dihydrofolate reductase. DNA, RNA polymerases. Monoamine oxidase, I already told you, para-hydroxyamphetamine, pargeline, okay, numerous others. Sodium potassium ATPase, reverse transcriptase, okay, dealing with HIV indications. So drugs that inhibit transporter system include those for transporters involved with reuptake of dopamine, norepinephrine, and 5-hydroxytryptamine. So you're mediating the first steps in signaling by insulin. On insulin you have tyrosine kinase. Okay. You're mediating growth factors. You're mediating platelet-derived growth factor, PDGF. A description about tyrosine kinase is addressed to you here. Membrane spanning, macromolecules. You have various polypeptides, 2 alpha and 2 beta. It has a specific recognition sites for binding with insulin, and essentially the growth factors located extracellularly and undergo conformational change. We're probably going to see that when we address thyroid hormones in endocrine system. Beautiful slides presentation on that. You're going to see it. This is the story here. Binding of ligand can be a drug, can activate those tyrosine kinase to carry on the phosphorylation of specific receptors. Cytokines, we dissecting this figure, this table that we addressed it. If you recall, before I leave, I do not want to lose any of you. See here, we're dissecting this one. Yeah, see that? We're dissecting this one, and along with this guy here. See here, cytokine receptors. So you have to keep in mind, well, what's the time scale? Hours. You're dealing with cytokine receptors. So you're dealing with protein kinase receptors. You're dealing with protein phosphorylation, gene transcription, and protein synthesis. And that's why it's slow. So we're done with this class, we're done with this class, and we are here on this class. You cannot ask for more than that. That's a beautiful presentation here. Okay, do you agree with me or no? Yeah, just send me a message and I welcome your opinion. So with cytokines, you're dealing with interferon and somatotropin. You're activating separate tyrosine kinase. You're dealing again with phosphorylation reactions, gene modifications. So it's an elaboration of what we mentioned in the past. G protein, common examples, adrenergic receptors, beta 1s, dealing with GS proteins, stimulation of G proteins. So you're dealing with cyclic AMP, GI inhibitory, decreasing cyclic AMP. We already mentioned that. Now we slow down on those last few slides. Adrenergic receptors, muscarinic receptors, and neurotransmitter receptors. That will be the end. Just 3 more slides and you're ready to go to autonomic nervous system. When we talk about adrenergic receptor, we talk about norepinephrine, epinephrine. They are catecholamine neurotransmitters. You're talking about autonomic nervous system. So those neurotransmitters of the sympathetic branch of the autonomic nervous system. You're talking about key receptors, GPCR receptors for adrenaline. What do we have here? So that's the adrenergic receptors. And then very soon you're going to address this class in detail, drug actions, mechanism of actions that we're going to elaborate on, and we're going to utilize some of this material. So what's left for us is actually to address the side effects and the mode of action of the specific ones, which one T have, and stuff like that. Nothing to worry about. Muscarine terminology is coming from mushroom, poisonous mushroom. Muscarinic receptors are picked up from this terminology. You're dealing with 5 subtypes: M1, M2, M3, M4, M5. Some of them are coupled to GQ proteins, others are coupled to GI proteins. If you recall, GQ will activate phospholipase, right? That's what GQ type of G protein that tends to activate phospholipase. So with this ones, what do you expect? Calcium, right? phospholipase, calcium. And that's what you're going to see when you move on to muscarinic receptors, drug involved, and stuff like that. How about GI proteins? Inhibition of adenylyl cyclase. You don't want to produce too much. Keep in mind that epinephrine, norepinephrine are considered neurotransmitters along with dopamine, serotonin, acetylcholine, monoamines. They have a specific transporter. They love sodium potassium co-transporter. A common antidepressant agent, Prozac, interacts and inhibits the serotonin transporter. Prozac belongs to SSRI, selective serotonin reuptake inhibitors. We're going to have our story in cocaine. Binds several neurotransporters, and that is the end of today's lecture. So in keywords, that actually concluded pharmacokinetics and pharmacodynamics. In keywords, I'd like you to have an appreciation about pharmacokinetics parameters, to have an appreciation about T-half, to have an appreciation about biotransformation, to have an appreciation about phase 1 and phase 2, to have an appreciation about C0, how you can, from a graph plot, how can you determine T-half of a drug and what does it mean from a clinical point of view when you adjust the dose and things like that, and how can you get C0 from a plot. To have an appreciation about drug modification. To have an appreciation about elimination of drugs. Hydrophilic versus hydrophobic, retention of drugs. How you enhance the excretion of a drug that is unwanted. To have an appreciation about the modification that takes place in order for a drug to pass through the blood-brain barrier. That's pharmacokinetic aspects. Pharmacodynamics, you're dealing with drug-receptor interactions or a non-receptor mechanisms. So you have to appreciate that. Drug-enzyme interactions. You have to appreciate graphs, efficacy, potency, affinity, ED50, and molecular signaling mechanism. Cyclic AMP, GMP, cyclic GMP, phospholipase, calcium, GS, GI. Give examples. Appreciate them, love them, and you got it made. You got it made. Thank you all for attending this lecture, and please, please, please send me your comments, and please pass the word. I see here some questions, so let me address that. Diana. Find the question, yeah. Okay. I release the microphone to you. Diana, you want to talk?
Hello, can you hear me? Can you hear me?
Yeah, Diana here wants to talk. All right. Okay. Talk, Diana. What's in your mind?
Can you hear me now?
Hello? I release the microphone to you.
Hello? Can you hear me now?
Where, yeah. What part of the country you are from?
I'm from northern Romanian. Do you hear me?
Somehow. Okay. Okay. So please send me your comments and perhaps send me your a question, and I will be more than happy. Oh, let's see. Okay, Diana, I released you. Okay.
Can you hear
Thank
me
you
now?
very much, and we'll end up today's lecture on that. Appreciate everything. Thank you, thank you, thank you. Bye-bye.